Please join me in welcoming Dr. Atay Rosenthal.
Dear colleagues, today's topic will be gastric cancer imaging, and I'll be talking about, as Rina mentioned, the epidemiology, pathology, staging, and the differential diagnosis. Gastric cancer is the fourth most common cancer and the second leading cause of cancer-related death worldwide. There are about 930,000 new cases of 700,000 deaths per year. The highest incidence is in Japan, with 100 new cases per 100,000 people per year, with the stomach cancer being the leading cause of death from all malignant diseases. It happens to be the most common cancer in Korea. It is one of the least common cancers in North America, but remains the 8th leading cause of cancer-related death. There are two main sites for gastric adenocarcinoma, proximal or distal. Proximal cardiac cancers and the other name adenocarcinoma of the esophagogastric junction now is recognized as a separate tumor entity with a rising incidence in the Western world. There are two types to it. Type 1, where it is the distal esophagus involved, where there is association and more incidence with the Barrett's mucosa, up to 55% of the cases, and the lesions are highly FDG avid, as opposed to the cardia type 2 cancer, where there is more association to the drinking and smoking history, and there is significantly lower glucose metabolism in these cancers. The non-cardia distal gastric tumors has been decreasing in incidence due to eradication of the H. pylori with the intensive screening programs. There are many risk factors, with H. pylori seropositivity being the highest risk factor, up to 17% fold increased risk compared to the negative individuals. That is through its role from chronic gastritis. If the patient has prior radiation or chemotherapy for other malignancies, dietary factors, obesity, tobacco smoking, if there is a history of gastric peptic ulcer, hypochlorhydria, pernicious anemia, Menetrier's disease, Epstein-Barr virus, these can be all counted in the risk factors. And post-resection gastric stump. There is about up to 6% increase after a 20-year latent period. And the earlier the gastric cancer when it was resected, the later the latency period. These are images, rest in peace, from my father. He had his original cancer in his 50s. About 30 years later, if you look at the images on the upper left corner, you see the gastric wall is kind of thickened and there is an increased enhancement to it. And the upper right corner image demonstrates with the arrowheads the low density metastases, which is typical for gastric cancer. And the lower two images on the left demonstrates featureless large bowel that is unrelated to his gastric cancer or maybe related stress-related factors. And there is increased fatty deposition about the colon with an enhancing nodule on the right lower quadrant. It shows his underlying long history of ulcerative colitis-related bowel changes. When we are talking about the histology, 90 to 95% of the cancers are adenocarcinomas, and there are two major categories. There are many classifications which I'll go over them. It can be well differentiated or intestinal type, or poorly differentiated diffuse type, non-intestinal, the other name. There are some major differences between the two. In the well differentiated type, which is the most common, up to 53%, usually the elder age is involved. There is a declining incidence in the US and England, and there is a high association with H. pylori. That is why the incidence is decreasing, because of the eradication programs. It has a better prognosis, and due to association with the H. pylori, it usually arises in the background of chronic gastritis, gastric atrophy, and intestinal metaplasia. The poorly differentiated type, usually in the younger age, unfortunately the incidence is increasing, and it usually presents with the diffuse thickening of the stomach. Unfortunately, in the Western world, 80% of the patients are detected with advanced gastric cancer with the poor prognosis at the time of the detection. That's why in countries like Japan, there is very intensive screening, and there is a new variant that's called early gastric cancer. The definition is the primary tumor is restricted to the mucosa and submucosa. That is, beware, irrespective of the metastases at the time of detection. When we talk about the symptoms of the gastric cancer, they are usually vague, and if there are symptoms, it's usually the late stage. And the vague symptoms are some dyspepsia, weight loss, anemia. But if the tumor is located in the cardia or in the pylorus, there may be an obstruction, as the patients may present with it. Sometimes, unfortunately, the first sign is the metastasis. We see isolated nodal met in the left supraclavicular region that is called Trosa sign or Virchow's nodule. As I mentioned, because it is one of the oldest diseases, there are many classifications, like in Borman's classification, which is made in 1926 but still is valid, which was the classification for the advanced gastric cancer. There were 4 types: polypoid, fungating, ulcerated, and infiltrative. Then there are other classifications, as it's seen in the slide. But the most common use is the Japanese Society for Gastric Cancer classification, 1981, and then World Health Organization. When we are looking at this slide, it shows the gross pathology of an intestinal type, well-differentiated adenocarcinoma. There is a fungating tumor growing mainly into the lumen. It may also be flat, ulcerated, and deeply invasive tumor going through the wall of the stomach. And the appearance depends on the mucin produced or the desmoplastic reaction by the tumor. That desmoplastic reaction is important to know because if there is, the adjacent gastric wall is also thickened. That is why the biopsies sometimes are inconclusive in these patients. This is a gross pathological example of an intestinal type, again well-differentiated adenocarcinoma, where the gross appearance resembles the ulcerative type, showing marked resemblance to the chronic peptic ulcer. We are showing here the diffuse type of adenocarcinoma, poorly differentiated, where the changes usually begin in the peripyloric region, and that's why these patients can present with obstruction. The wall gets thickened and rigid, and that shows the gastric diffuse wall thickening and rugal prominence. This image shows the early gastric carcinoma histological slide. As I mentioned, it is regardless of the status of regional lymph nodes, and it's usually the intestinal type. Beware that the name is inaccurate because it is not really related to the duration of the lesion. It has other names also called surface cancer, superficial cancer, superficial spreading, or microinvasive cancer. I like this slide taken from Dr. Chan's work. On the left, we see the Japanese classification of early gastric cancer, and on the right, we see the Borman's classification of advanced gastric cancer. They may be still called type 1, 2, and 3, but we are talking about different entities, where in the Japanese classification, the form is confined to the mucosa and submucosa. What do we do in CT? The CT is the mainstay usually for detection and the follow-up of the patient. First, if we are doing the virtual gastroscopy part and endoluminal imaging, we give first gas-producing crystals with a small sip of water and do an unenhanced CT, starting above the diaphragmatic dome to below the lower margin of the air-distended gastric body using a thin collimation. Then we can follow this using a 1,000 to 1,500 cc of water or Omnipaque oral solution that is given over 20 minutes. A high rate of contrast injection, 3 to 4 cc's per second of 100-120 cc of Omnipaque 350. The acquisition typically obtained within a 50-second delay in a single phase. That also corresponds to the portal venous phase, which is about 50 to 60 seconds post-injection, and that happens to be one of the best sequences assessing the gastric malignancy. Arterial phase imaging provides little, if any, additional information, but in countries where there is a high gastric cancer, there are even 3-phase arterial enhancing images, arterial, portal, and delayed equilibrium phase. And venous phase imaging seems to be the best in terms of detection of the liver metastases and to evaluate the small lymph nodes that are important and separating them from the adjacent vascular structures. Here it shows a beautiful slide, I think, where on the upper left corner you see there is, it's an enhancing CT. There is a high density material, maybe the patient has ingested something. But when we look at the arrow pointed lesion here, we see a very small enhancing lesion submucosal in the gastric wall. This was benign glomus tumor in the arterial and portal phase. It's, I like to show it because they are not common, they are quite rare tumors, and this may be the time to see it. And in the upper left image, we see the small submucosal tumor with a speckle of calcification, if you can appreciate that. And it is vividly enhancing, it is submucosal. That was, after partial gastrectomy, a glomus tumor again in the lamina propria of the antral mucosa. This was a 12 millimeter lesion, so if there is not enough adequate gastric distension, that will be very difficult to see. As opposed to this case. Again, we are seeing a very small lesion that's a 63-year-old male with a gastric polyp, demonstrating with the arrows an enhancing lesion. So it's important to detect these lesions because if you look at the lowermost images, this is one of the slides that are a little bit lower, it shows the patient had a left nephrectomy. That was back in 2003, and there was a metastasis to the distal pancreas, had pancreatectomy, now it is the gastric metastasis, which is not uncommon for the renal cell cancer. That's why in these patients arterial phase imaging is very important. And we are looking at an 83-year-old male who had an upper gastrointestinal hemorrhage, where the EGD demonstrates esophagitis and gastritis. But the pathology was infiltrating moderately differentiated gastric adenocarcinoma. On the left image, without the proper gastric distension, we see the whole gastric wall thickened. And on the right side, when the negative oral contrast was given with an arterial phase imaging, we see the thickening more confined to the cardia. This patient also received FT18 FDG, and we see the intense activity localizing to the thickened gastric proximal lesser curvature. So FDG is pretty good in terms of localization of these lesions. In the evaluation of the CT, we look at the key images, which are usually the axial images, MPRs, especially coronal imaging, and 3D images with volume rendering. One important thing to know is the normal gastric wall. It can have different appearance, usually has a 2 or 3 layered pattern. There may be a markedly enhancing inner mucosal layer, an intermediate hypoattenuating submucosal layer, and a very thin outer layer, slightly high attenuating muscular serosal layer. This image, I hope it reflects on the slides well. On the upper left corner image, we see a single layer gastric wall. On the upper right image, we see in this patient there are 2 layered appearance in the distal gastric antrum and proximal greater curvature. And on the lower left corner of the image, we see a 3-layered appearance of a normal gastric wall. Sometimes in the same patient, you can see different layered appearance in different walls. So important to know the normal appearance. Staging is the most important part of evaluation of gastric cancer. An accurate preoperative staging regarding to the depth of mural invasion, nodal involvement, if there is any adjacent organ invasion or distant metastases, is very essential in terms of planning the surgical approach to decide if there is going to be neoadjuvant chemo or radiotherapy with this patient, and what is the risk of tumor recurrence and overall prognosis with this patient. In T staging, we assess the depth of tumor invasion into the wall of the stomach, to the surrounding adventitia, serosa, fat, and adjacent organs. According to the TNM classification system by the AJCC, there are 4 stages on this T. Pathologic T1, when the tumor is confined to the mucosa and submucosa. In T2, it extends into the muscularis propria or subserosa, but we still see a clear fat plane. In 3, we see the tumor extending through the serosa without involving the contiguous structures, and T4, the contiguous structures are involved. Now, what do we see in CT? That is the corresponding T1, T2, and T4 staging in CT criteria. On T1, we see a focal thickening inner layer, where the tumor invades the lamina propria. In T2, we see focal or diffuse thickening of the gastric wall. There is a transmural enhancement now, but the clear fat plane around it. And T3, we see the tumor with the irregular and nodular outer border. There is perigastric fat infiltration or not. And in T4, there is already adjacent organ invasion. Now, these are the examples that demonstrate it very nicely. In a coronal reformat image, we see a focally enhancing lesion in the upper lesser curvature of the stomach. As you see, there is an outer strip of hypoattenuating submucosal layer and no perigastric invasion, T1. Here we see a increased thickening, but the thickening involves throughout the wall. It's a transmurally enhancing mass with ulcerations demonstrated with this arrow. There is no perigastric invasion, clear fat plane, T2. This is in a Bormann type 3 patient, Dr. Chan's work. You see, in Japan, they do 3-phase enhancing studies in the arterial portal and the late equilibrium phase on the right images. On the upper left, there is a virtual gastroscopy, and underneath is the pathologic specimen. We see how the imaging is getting close to the real pathology, and that's demonstrating a transmurally enhancing lesion with clear fat plane around the gastric wall, T2, pathologic T2 stage. Here, in a coronal reformatted image, we see a stage T3 tumor where the arrows are pointing that there is gross infiltration into the perigastric fat tissue in an antral lesion. It's another patient in T4 stage tumor where there is extensive infiltration beyond the gastric wall, and there we see the pericolonic thickening of the walls and stranding. Another T4 stage tumor in the gastric body, inferior extension of the tumor to the gastric pancreatic tail as we see, and reverses through to pancreatic lesions can invade the gastric wall. Another patient demonstrating the T4 tumor where the invasion is seen to the lateral segment of the left hepatic lobe from the gastric wall with adjacent extensive infiltration. This is a case where on the axial CT scan we see a diffuse thickening of the nearly entire gastric wall that are shown in the arrowheads, and this patient received an FDG and did an FDG imaging study where we don't see that much of a significant uptake in the gastric wall because it was a signet ring cell carcinoma without FDG uptake in this 30-year-old woman with stomach cancer. We are talking about the end staging. End staging is one of the most important stages. According to the TNM staging system developed by AJCC in 2002, there are 3 end stages. These are the number of lymph nodes involved by the disease. N1, when there is up to 6 regional lymph nodes involved. N2, when there is metastases up to 15 regional lymph nodes, and N3 if there are more than 15 regional lymph nodes involved. So there are other N classifications as well, such as N1 being the lymph node involved lymph node within 3 cm from the tumor margin, and N2 more than 3 cm away from the tumor margin. But this classification is more correlative to the estimation of prognosis. This slide shows where the perigastric lymph nodes are involved. One thing is important. This is from the Japanese Research Society for Gastric Cancer, lymph node location and stations. I colored them differently. On the left, there are 16 lymph node stations. Each one is colored, each group is colored differently. Up to 6 perigastric closer lymph nodes, where the lymph nodes are in the right and left pericardium, in the lesser greater curvature, supra and infrapylorus region. This is the group 1 lymph nodes. And from the left gastric artery, common hepatic artery, we are starting to get a little bit further away from the gastric wall, celiac, splenic hilum, and proximal splenic artery. These are the group 2 lymph nodes. So important to know these lymph nodes and what groups they belong to. And it's always important to remember, like anywhere in the body, the lymph nodes travel with the arterial anatomy. Now, according to this Japanese Research Society's gastric cancer classification, as I mentioned, these lymph nodes go into certain compartments. One thing important to know about this compartment system is if the cancer is located in the lower third of the stomach, the lymph nodes along the splenic artery are no longer compartment 2 but compartment 3 lymph nodes, and compartment 4 lymph nodes are the distal ones. Now, in Japan and Korea, where there is extensive gastric surgery, the standard surgical procedure for gastric cancer is D1 and D2 lymphadenectomy. These are dissection of the lymph nodes that are in close proximity to the stomach wall. And if these two lymph nodes are dissected, this D1 and D2 lymphadenectomy is done, there is higher chance of cure. When we are talking about D3 and D4 lymphadenectomy, that's more extensive disease. when in D3 up to 3 compartments and D4 all 4 compartment lymph nodes are involved. But in the new AJCC classification, the regional lymph nodes from 12 to 16 are distant metastases, and the extent of lymphadenectomy, as I mentioned, depends on the compartments involved. Lymph node status is very important because it can be one of the single most prognostic factor in some articles, but it is an important prognostic factor. And the 5-year survival rate, it can be up to 86% if there is no lymphadenopathy with the disease, but it drops dramatically to 6% if it is an entry gastric cancer. What do we see in CT? We don't always successfully separate them, but if there is solitary or separate nodes 8 mm or greater in the lung axis, if they are nearly round in shape, if there is central necrosis, they show marked and heterogeneous enhancement when there is an above 8-5 Hansfeld units in the post-contrast portal venous phase, or there are cluster of nodes or solitary nodes with associated reticular stranding, then we don't depend on the size or enhancement pattern. This is a case demonstrating very nicely the CT and the FDG imaging of station 7 adjacent to the left gastric artery in the arrowhead and the arrow, and then another station 8 lymph node adjacent to the common hepatic artery in this gastric wall thickened gastric cancer patient, where we see both lymphadenopathy having an intense FDG activity as well as the primary gastric tumor suggesting metastases. Unfortunately, CT has major limitations detecting which lymph nodes are cancers involved. It can be normal-sized lymph nodes. Cannot differentiate between the reactive hyperplasia or metastatic enlargement. And up to 55% of the metastatic lymph nodes in the literature were found to be 5 mm or less in diameter. So that's difficult to detect. Such as this patient, there are cluster of lymph nodes on the right infrapyloric region in this advanced gastric cancer in a 63-year-old woman, where those lymph nodes were positive. However, where the arrowhead points, there is a low-density cystic appearing lymph node adjacent to the gastric wall, which it was found to be reactive in the histopathological analysis. Talk about M staging. Solid organ metastasis is uncommon in primary gastric cancer at the time of the initial diagnosis, and if it is usually to the liver through the hematogenous metastases because the stomach wall is drained by the portal vein. And thing to remember is that they may be hypovascular, usually actually hypovascular, and occasionally they may show rim enhancement. There are less common sites, lungs, adrenal glands, even the skeleton in the advanced cases can be involved. There is a special name when there is ovarian metastases. It's called Krukenberg tumors. It doesn't have to be only peritoneal dissemination, but it can be disseminated lymphatic or hematogeneously. They are usually large bilateral adnexal solid masses with heterogeneous contrast material enhancement. Here we see, you may see lots of cystic lesions. This demonstrates a little bit peripheral enhancement in this patient with hepatic metastases, with stomach cancer, multiple cystic nodules in the liver, and they were very highly FDG avid. In this patient of a 34-year-old woman with stomach cancer, we see the heterogeneously enhancing mass and ascites demonstrating high FDG activity in a Krukenberg tumor. In M staging, I need to emphasize again, if there is distant lymph node metastases, supraclavicular lymph nodes, compartment 3 and compartment 4 lymph nodes, they are considered as distant metastases rather than nodal mets, and they preclude at that point the curative surgery for the patient. Like this case, in CT, we always see supraclavicular less than 1 cm lymph nodes. Here, when we did the FDG imaging on this patient who was 44-year-old woman with stomach cancer, we see the intense activity in bilateral supraclavicular region. And you see like a river mirror heart image, you see an intense gastric activity as well in the lowermost part of the slide on the right of the FDG activity in the gastric cancer. Peritoneal metastasis is extremely unfavorable prognostic factor, implying that the disease at this point is incurable. If we know that preoperatively, we can avoid performing unnecessary laparotomy. and we can decide if the surgery is going to be potentially curative or palliative. CT still remains the modality of the choice for the pre-op diagnosis. PET has unfortunately low sensitivity, and unfortunately these are only detected intraoperatively. Using thin section collimation and MPRs enhances detection of the peritoneal metastases. If there is ascites, always be careful. It's one of the most common findings. In advanced cases, as we all know, we see the nodular plaque-like or infiltrative soft tissue lesions. Parietal peritoneal thickening or enhancement can be seen, but look in the small bowel as well. They may be distorted, a little bit wall thickening, they may be involved with peritoneal metastases. When we see a case like this, it's quite straightforward. We see the nodular strands of omental infiltration seen in these coronal reformat images, and on the right we see the ascites and arrows pointing to the parietal peritoneal enhancement, considering the peritoneal metastases. In the same patient, when we do the FDG imaging, all we see is increased diffuse bowel uptake without obscuration of the visceral outline. And it is difficult to differentiate between the physiological uptake and tumor seeding. And also this patient, again in a 38-year-old man with the stomach cancer, there is extensive metastatic nodules, parietal peritoneal enhancement. And in the FDG, all we see is the diffuse, hazy, increased activity throughout the abdomen with the obscuration of the normal visceral outlines. Another patient, we see then you see it, every patient looks about the same. You see the omental nodularity in this patient, and coronal reformat images, if it projects well, shows the diffuse infiltration, and the transverse colon is nice to look at because transverse mesocolonic nodular enhancement and infiltration is seen better. As opposed to this patient, it's a little bit more difficult to see the peritoneal carcinomatosis on this patient. It was an interesting 76-year-old female, one episode of acid reflux, and she obtained an EGD. It was non-specific, only demonstrating chronic inflammation. But on CT, we see on the upper left corner the rigid stomach, enhancing wall, and adjacent subtle omental infiltration. This patient, a couple days later of this study, obtained another CT, and we see a very distended distended bowel. That was also presentation with a sigmoid volvulus through to peritoneal metastases. So it's important to look at every part when you see an emergent case of a sigmoid volvulus. There are many other disease entities that can present in the imaging, like gastric carcinoma. We look at other associated findings with these patients. If there is metastases, especially lung and breast, they mimic the diffuse type rigid antral wall, non-Hodgkin's or Hodgkin's lymphoma, chronic systemic or inflammatory conditions, including sarcoidosis, corrosive gastritis, amyloidosis, Crohn's disease, graft versus host disease, eosinophilic gastritis, and there is a long list including gastric plasmacytoma. Lymphoma is important to separately mention because it is the most frequent, the stomach is the most frequent site of involvement in the GI tract by non-Hodgkin's lymphoma. It typically appears as segmental or diffuse wall thickening, typically involves more than one region of the stomach in contrast to gastric adenocarcinoma, and lymphoma we know is a soft tumor, so it's less likely to result in gastric outlet obstruction. Perigastric adenopathy is common as gastric adenocarcinoma, and if the adenopathy extends below the renal hyla, it favors gastric lymphoma over adenocarcinoma, and they are usually very FDG avid. Here we see a patient, two different patients demonstrating segmental thickening in the gastric wall. The gastric wall thickening is a little bit less denser than the gastric adenocarcinoma. We see these two different patients, endoscopy revealing gastric lymphomas. Let's come to our first case. Question 1. This is a 76-year-old female who had an antral ulcer and a bleeding about 3 years ago. There were no GI symptoms, and a routine follow-up study demonstrates an antral lesion, and the biopsy of this lesion was chronic antral gastritis. The patient has A. gastritis, B. gastric cancer, C. lymphoma, D. gastric polyposis. So we'll start with 15-20 seconds of polling. So let's see the results. Oh, audience response. Evet. Yes, it's gastric lymphoma. It's very nice. So audience responded. Interesting thing in the CT on this patient, we don't see any abdominal adenopathy. But it was right, as the audience, gastric malt lymphoma was found in the gastrectomy specimen, and there was no other site of disease. What about this patient? It's a 49-year-old female, incidental gastric mass on CT. This patient has A, leiomyoma, B, gastric cancer, C, lymphoma, D, neurogenic tumor. And we start the 15 seconds. Actually, it's 20 seconds now. Yeah, that's true. It's not easy, straightforward answer. The audience response is between gastric cancer and neurogenic tumor. Rightfully so. Here, it was after the partial gastrectomy. The answer is neurogenic tumor. It was a schwannoma that was extending to the lateral serosal margins of the resection with overlying mucosal ulceration that's shown in the upper right image where there is the ulceration. So schwannoma, it's not always straightforward to differentiate these masses, but the adjacent gastric wall is not involved. What about this patient? 68-year-old male presents with large cystic abdominal mass. The patient has A, pancreas mucinous cystadenoma, B, GIST, C, lymphoma, D, gastric melanoma. And 15 seconds start. 15 to 20 seconds. We're about there. Yes, we are divided between the gastrointestinal stromal tumor and gastric melanoma. When we see a very large mass in the abdomen, first thought, especially if it's a cystic heterogeneous mass, is GIST. This tumor was a 27 centimeter tumor, was a unifocal, it had a high mitotic rate above 5/50 high power field. So gastrointestinal stromal tumors are uncommon neoplasms that arise from the mesenchymal cells in the wall of the gastrointestinal tract. They can be classified histologically as myogenic tumors arising from the smooth muscle, neurogenic tumors if they are arising from the neural elements, or less differentiated tumors. In CT, the appearance and size vary. 90% occur in the fundus and the body of the stomach. Small tumors appear as intramural masses, but as they grow, they stretch the overlying mucosa and can ulcerate. If they are large, more than 5 centimeters, they often appear exophytic and may contain areas of central necrosis and calcification. Associated adenopathy is uncommon, that is in contrast to the adenocarcinoma or lymphoma. They can invade the adjacent organs and they can metastasize. Metastatic lesions also appear low in attenuation due to its necrosis. And CT is difficult to cannot help always to differentiate between the malignant and benign tumors unless there is obvious invasion or metastatic disease. But usually if they are less than 4 or 5 centimeters are benign. And the resection and histological analysis is necessary. They are usually very FDG avid. This is the two examples. On the left, we see a coronal contrast enhanced 3D volume rendered CT image. There is a large ulcerating exophytic mass that's arising from the stomach that was comparable with a malignant GIST. And on the right, we see a coronal oblique again image that is a smooth gastric mass in the antrum that was a benign GIST at surgery. This patient, we see on the coronal reformat images a very large tumor that's arising exophytically from the gastric fundus. and on the right we are showing it with the arrow. If you notice the adjacent gastric wall, that may help to differentiate from gastric adenocarcinoma, because these tumors do not produce desmoplastic reaction, is not thickened. And we see a cystic lesion in the liver. Please don't pass them by. That was a cystic hepatic metastasis in a malignant GIST patient. Fourth patient, 67-year-old female who had a small bowel resection in 2005 for GI bleeding. Serial CTs since then has been negative for the last 6 years. Recently she had an acute chest and back pain, went to the emergency room, got a PE study. So this patient has A, hydatid cyst, B, gastric cancer metastases, C, GIST, D, ovarian cancer metastases. And we start the timing. Okay. Audience response is again divided between the gastrointestinal stromal tumor and gastric cancer. Okay, it could have been the hydatid cyst too. It's not our subject, but let's see. I like the imaging aspect of this patient. That was a recurrent GIST tumor, metastatic to the stomach, and in this slide how it shows the original tumor and the metastases have the same imaging characteristics. Gastritis, inflammatory conditions of the stomach, can be the mimics of gastric cancer. The CT is usually performed due to non-specific complaints in these patients. And most common CT finding is thickening of the gastric folds and wall. But in severe cases, sometimes the gastric wall may demonstrate a low attenuation submucosal layer due to submucosal edema and inflammation. And mucosa enhances due to hyperemia. When there is this layered appearance, it is also called the halo sign that may help us to distinguish gastritis from other conditions. Not always reliable, but it will be helpful. Gastritis, unfortunately, can happen and appear only focal or segmental thickening, especially in H. pylori gastritis. Particularly, it may simulate a gastric carcinoma because it can often result in circumferential antral wall thickening or focal thickening along the greater curvature of the stomach. When we do a volume rendered image, demonstrates very diffuse fold thickening. As you see, the folds are thickened, not exactly the gastric wall. That was gastritis. That brings us to our fifth question. These are the coronal and coronal oblique contrast enhanced 3D volume rendered CT images demonstrating circumferential thickening of the pylorus. So this patient has A, leiomyoma, B, normal gastric antrum, C, lymphoma, D, adult hypertrophic pyloric stenosis. And the time starts. Okay. So we are giving a couple more seconds. You'll be in charge, Rina, about the timing.
I will watch the clock.
Okay. We are divided between the normal gastric antrum and the adult hypertrophic pyloric stenosis. I totally agree. Normal gastric wall is up to 5 millimeters, 10 millimeters in some places. In the gastric antrum, we can go up to 12 millimeters. But in this patient, when the surgery was needed due to stenosis after partial gastrectomy, it was found to be an adult hypertrophic pyloric stenosis that has resulted from the chronic peptic ulcer disease. PET and PET-CT in evaluation of the gastric tumors and staging. The articles are giving different information about it. FDG PET has limited role in the gastric cancer staging, especially if it is locoregional staging, due to intense activity in the gastric wall, preventing us to depict the lymph node activity. But if we see it, as we showed another example, that's important. And there is a high variability with the FDG activity in the stomach from patient to patient due to high physiological uptake in the normal gastric wall that can be caused by dense blood flow. It can be due to inflammatory diseases, physiological emptying, and visceral thickening. The important thing to know, depending on the histological types of the gastric cancer, we see variation in the FDG activity, especially if the non-intestinal diffuse type, mucinous adenocarcinoma, or carcinomas containing signature cells, they can display consistently low detectability, but they may be high intense in activity as well. As opposed to tubular carcinoma and moderately differentiated type, they demonstrate significantly higher activity. And in T-staging, the sensitivity of PET ranges from 26 to 63% in early gastric cancer, up to 98% if there is a locally advanced gastric cancer. Important to know that normal gastric wall has increased FDG activity, okay, but there is a different pattern of normal FDG activity in the stomach. In this patient, in the coronal reformat images, and on the right fusing to the CT images, we see the activity more in the proximal gastric body and fundus of the stomach, with gradually tapered activity distally. This is the normal pattern of activity. So if we see a patient in the gastric antrum or distally, there is, even if it is a normal uptake, but it's higher than the gastric fundus, we start to worry. And there is a number of 4. It has been found statistically significant. If the activity is more than 4 SUV value, then we need to send this patient to endoscopy to rule out underlying benign or malignant reasons. And FDG helps us in terms of SUV values. There has been found a high correlation between the SUV and the primary tumor size, between the primary tumor SUV and the presence of lymph node metastases. If there is a higher SUV, poorer the prognosis is. And it's a predictor of neoadjuvant chemotherapy-induced clinical and histopathological response. Like in lymphoma, after the first dose of chemotherapy, if there is a decreased activity, we can say the patient will be responding to the chemotherapy. FDG is also relatively accurate in detecting recurrence in postoperative patients with a high positive predictive value of 87% per lesion based, and it can also be used as a non-invasive diagnostic test to assess tumor aggressiveness and to predict the patient's survival. 6th question. It's a 69-year-old male who has weight loss and nausea. We are seeing the upper GI images. And the EGD demonstrates lenitis plastica, but the biopsies were inconclusive in this patient. We see the FDG and contrast-enhanced CT images. So the patient has A, peritoneal carcinomatosis, B, lymphoma, C, stage 2 gastric cancer, D, tuberculosis. And the time starts. Yes, we are also confused with the stage 2 gastric cancer in this patient. In stage 2, if we remember, yes, the diffuse gastric wall is thickened, but in this patient there is ascites and there is peritoneal infiltration. This was an end-stage invasive, poorly differentiated adenocarcinoma with signature cell features. So you see there was a very high intense FDG activity despite the patient had a signature cell, and there was peritoneal metastases, elevated CEA and CA19-9. We see the coronal images demonstrating the infiltration better as well as mediastinal adenopathy. What about this patient? 43-year-old female patient comes with GI bleeding. The patient has A, gastric cancer, B, lymphoma, C, GIST, D, metastases. Let's see. I'm getting curious too.
We need to add music
That can be
at
nice.
this point, I think.
Yeah, or jokes.
Yes, we can ask Leonard to sing.
The audience response is rightfully mostly on metastases. Yes, it's an interesting metastasis in this patient who had melanoma. The initial disease with this patient, was a young patient, was in 2003, 7 years ago, with stage 1B malignant melanoma. And it was a wide excision with negative sentinel lymph node biopsy at the time, but presents 7 years later with a large gastric mass. What about this patient? 72-year-old Korean male, EGD and endoscopic ultrasound demonstrating, I'm giving you the findings, a right upper quadrant exophytic mass, and the biopsy demonstrates A. Leiomyoma, B. Gist tumor, C. Accessory pancreas, D. Carcinoid. That's true. The majority mentioned the finding, but we are divided between gist tumor as well. Now, in these images, that's the coronal image. If you look at it, the enhancement pattern and the appearance of this lesion exophytic from the duodenal wall is pretty much with the original pancreas. So ectopic pancreas is a differential diagnosis in these tumors. That was only, the patient already went through resection, but was an accessory pancreas. Important to remember that perigastric masses needs to be better evaluated with intravenous contrast. Also beware that other vascular pathologies can mimic like gastric pathology. So it was an incidental perigastric mass that was discovered on a prior non-contrast CT. Good thing that the patient wasn't sent to biopsy, because after contrast enhancement it was a very large splenic artery aneurysm. What about this patient? It's a 44-year-old female who has kidney stones. Incidental discovered right upper quadrant mass on CT. The patient has A. Gist tumor, B. FNH, C. Neuroendocrine tumor, paraganglioma, D. Hepatoma. And we can start taking answers. Yes. The audience response again divided rightfully between FNH and neuroendocrine tumor. It's not complex looking to represent a GIST tumor. And these are the arterial and portal venous phase images with the axial CT. If you look carefully, you can almost make the central scarring, but that wasn't enough. The patient went through resection. These are the coronal MIP images, how nicely demonstrating the feeding vessel coming from the common hepatic artery on this patient. That was an FNH, exophytic from the liver, mimicking like a gastric mass. What about this patient within the spectrum of gastric cancers? 66-year-old Korean female, usual health till 609. She started to losing her taste, developed abdominal cramping, diarrhea up to 20 a day, developed red bumps over her torso, arms and legs. She began losing her hair and nails and began losing weight of 80 pounds. These are the upper GI images. So, A, she has familial adenomatous polyposis. B, risk of GI malignancy is 90%. C, GI changes are generalized hamartomatous polyposis. D, it is a rare familial syndrome characterized by marked epithelial disturbances in the GI tract and the epidermis. You can take the answers now. Yes, that's what I was expecting, dividing between the familial adenomatous polyposis and the choice D. So these are, it's a little tricky question, none of the answers are correct, but these were the GI changes, generalized hamartomatous polyposis, which was a Cronkite Canada syndrome. Quite rare. We happen to see one case here at Hopkins. It's extremely rare. So it's a rare non-familial syndrome. It's characterized by marked epithelial disturbances in the GI tract and epidermis. The GI changes are generalized hamartomatous polyposis with abnormal intervening mucosa. Fluid and electrolyte abnormalities, malabsorption, malnutrition, GI bleeding, and surgical complications can happen. The prevalence of GI malignancy is about 10%, and this patient had all the epidermal manifestations. Yeah. Oh, there is more answers coming in. Yes, there is more C now. There are more right answers come. So the lecture will pause for